Go ahead.
It is my very great pleasure to introduce Tijn. The first and most important thing about Tijn has been a wonderful colleague through ESPA over the years. And that's the most important thing to say about him, I think. You can read about his biography, it's very impressive, but you can read that yourselves. The other most important thing, he just got news a few minutes ago that a workshop on mindfulness with Jasmine, with Catherine, with Christina has been accepted for ISCOS. So that is a wonderful tribute to the work that he's been doing. There's two important things happening in Europe this week. One is this conference, and the other is the Eurovision. If there was a Eurovision, the Netherlands would be up there, because between Marcel, Christelle, and today we have Irina as well, the Netherlands has always flown the flag so well. I think the Netherlands and UK would probably be the Sweden and Ireland of the Eurovision Song Contest. And for anyone who doesn't know, that means that Ireland has won the Eurovision 7 times and Sweden has won it 6 times. So I think the Netherlands and the UK can battle it out at lunchtime. Tijn is a healthcare psychologist, he's a rehabilitation psychologist, he's a neuropsychologist, he's a cognitive behavior therapist, he's clearly a mindfulness trainer, he's fitted in a PhD. He's only doing the research. He's also a researcher and completed his PhD in 2020 in Utrecht. So hugely impressive, and I'm really looking forward to hearing what he has to say.
Thank you very much. Thank you, Wee, for your kind introduction, and thank you, ESPA, especially Jane, for asking me to do this keynote. I'm very excited to do it. Also very nervous, so when you see that, please be gentle with me. I'll talk to you today about self-efficacy. Jane asked me to do this presentation partly because of the thesis that I wrote, and that was of the Self-Efficacy study. And the Self-Efficacy study was granted by the Dutch Rehabilitation Foundation, so we granted that, but the sponsor had no influence on any of the results, and I have nothing else to declare. Today I will talk with you about self-efficacy, what it means, how you can understand this concept, but also about the Self-Efficacy study and all the studies that came from it. Some have been published, but most that I will talk about, not yet. We are working on that, so you get a lot of new information, I hope. And I try to find the right balance between science and practical helpfulness of this information. If you are interested in my thesis, please send me an email and I will send you a PDF back. The concept of self-efficacy. It was postulated by Bandura in 1977 as part of his social cognitive theory. And he was talking about how people realize their goals. And there are 4 main things that are important according to Bandura: self-observation, self-evaluation, self-reaction, and self-efficacy. And especially the last one has got a lot of attention and will also be the subject of my talk today. When we look at the definition that Bandura used, he said that self-efficacy is one's belief in one's ability to succeed in specific situations and accomplish a task. And I found it a very hard concept to understand until I realized that it is about the belief that we have that we can succeed. And when you're talking about the belief that you have that you can succeed in a task, then you are actually talking about confidence. And the other thing that comes in mind when you look at the definition is that Bandura is talking about specific situations. And here is something funny going on, especially when we look at all the skills that are made to measure self-efficacy. Then we see that there are a lot of levels, actually, and most of the self-efficacy skills are what you could call a general self-efficacy skill. It's more the confidence you have that you can overcome problems in general. While we are more interested in what you could call the disability management self-efficacy. How confident are you that you can overcome all the problems with a spinal cord injury or any other physical condition? And I think we can go even further to a more specific level. For instance, how confident are you that you can do all the self-care, or you can handle your wheelchair, or you can this is my mind going not good, actually. To prevent pressure injuries to occur. Sorry. And in my belief, the general self-efficacy is more a trait variable, while the other are state variables. I don't think that the general self-efficacy will change much over time, while the disability management self-efficacy and specific self-efficacy will change over time. You could say that the general self-efficacy is the climate we live in, while the general of the disability management self-efficacy and the specific self-efficacy is the weather that we are having now. So we here in the sea climate, that means that the winters will not be very hard, the summers will not be very hot. And that means that's the climate, but it doesn't say if it's raining right now. And that's what is disability management self-efficacy, or the specific self-efficacy is about. Self-efficacy plays a central role in a lot of theoretical models. For instance, the model that was presented this morning by Jane and Paul Kennedy, but also for the spinal cord injury adjustment model, or the theory of planned behavior. And these two models formed the basis of the Self-Efficacy study. I depicted them here very shortly, and I will not go into detail, but what you see here is that there are many boxes in those two models, and we try to cover all the boxes in both models. So we implied the biological aspects, the psychological aspects, the social aspects, the appraisal, self-efficacy, and so forth. So we tried to cover all the boxes so we can also see if these models work for spinal cord injury, actually. So what was the aim of the Self-Efficacy study? The aim was to investigate self-management, self-efficacy, and secondary health conditions during and after spinal cord injury rehabilitation. I will not talk to you about the self-management aspect. I will focus on self-efficacy and the secondary health conditions. This study was done in all 8 of the Dutch spinal cord injury rehabilitation centers, and I don't know if any of you ever been participating in a multi-center study, but if so, then you know that you are absolutely unable to do all this work on your own. You have a lot of people working for you, gathering all the data, and these are the people that did the work. I'm only presenting it here, but they did the real work, and I'm really grateful for all of them on this slide, and even more, but the slide was full enough. So what did we do? We, all people with a recent onset of spinal cord injury that entered one of these 8 spinal cord injury rehabilitation centers, who was able to fill out a questionnaire, so no severe cognitive problems, no severe psychiatrical problems. They were asked to participate in this study, and we had an assessment in the first week after admission, then a very short questionnaire, 5 questions for 8 and 12 weeks, then a longer questionnaire at discharge, the week before discharge, then after 3, 6, and 12 months. That was the original Self-Efficacy study. And very recently, we were able to gather some money and do an extra assessment one time. So we did that at the end of last year. So that meant that some people were already discharged for 5 years, while others were only discharged for 3 years. I will present some of the data that we gathered. I was not able to do all the statistics, so it's somewhat sloppy, I would say. The inclusion started 2015, ended in 2017. Then the last people included, they left the rehabilitation center in May 2018, so the end of the data collection was 2019 May, and we did the extra one in September 2021. This is what we did. I don't expect you to read this all and see what we all did. I will talk you through, and especially the things that are important for today. One of the main measures that we used is the disability management self-efficacy, and we used for that the University of Washington self-efficacy scale. For the secondary conditions, we used the spinal cord injury secondary condition scale. We used the pain and fatigue, the HATS. I expect all of you to know that. Participation, I will talk to you about that later on. The demographics, the psychological factors, and there are a lot, as you can see, also the general self-efficacy, but also the self-care self-efficacy. These are the skills that I will talk about today. So we had 272 people entering in the study, and you see that there's a dropout along the line, but it's not too bad, I guess. It's 200 people still 1 year after discharge. Unfortunately, the last meeting, one of the biggest centers that would not participate in this extra measurement, so we miss between 20 and 30 people in this last measurement. What can we tell about this population? Mostly male, 55 years on average. Most Dutch people, 1/3 had a bachelor or higher education. 70% had a partner. 65% almost had a job before the spinal cord injury. And 1/4 of the people did have some sort of psychological problem or help before they entered the spinal cord injury rehabilitation center. Have had a traumatic lesion or have non-traumatic, half was paraplegic, other half tetraplegic. 22% had a motor complete, that means Asia A or B. And we found that 13%, that's a little bit higher than we heard before, had a traumatic brain injury prior to the spinal cord injury. It doesn't mean they had that traumatic brain injury together with the spinal cord injury. They had a traumatic brain injury in their history. Yeah. And they entered the study almost 5 weeks after the onset of spinal cord injury. So we see them, I think, quite early in their onset. So the first thing I will talk about you is the course of self-efficacy, and this is a study that we published in the archives. So if you want to go into more detail, please look at this article. And the aim of the article was to determine the latent trajectories of spinal cord injury, the self-efficacy, depression, and anxiety. And this trajectory is a statistical way of putting people together that follow more or less the same path over time. So you could say, if we look at the 272 people that we have, are there groups of people that follow more or less the same path for self-efficacy, for depression, and for anxiety? And we also wanted to see if there is a correlation between those trajectories. So we used the University of Washington self-efficacy and the HATS, and we used that at admission, discharge, 3, 6, and 12 months after discharge. That time, the latest data was not available. So I don't think that all of you know the University of Washington self-efficacy scale. Originally, it has 19 questions, and we used the short form with only 6 questions. And all the questions start with a phrase, how confident are you that you can? And then the 6 questions appear, and you can answer them with not at all, a little, quite a bit, a lot, of completely. And when you put it in a questionnaire, it looks like this. So when we look, I have to say, we used the T-scores. So that means that the mean score is 50 and the standard deviation is 10. And when we look at the average score that we found, then you see that at admission, the average score is 43. Then it goes up during rehabilitation to 45. And it goes back to 42, 43, 45. And the latest, we find a score of 47. When we do multi-level regression analysis, we could not find any differences over time for the first year. I was not able to redo that statistics for the 3 to 5 year follow-up. So I did a quick and dirty compare means, and then we find some differences, but I don't know if we put that in the multi-level linear regression analysis, if it still holds, but it seems that it's going a little bit up, and it's getting more towards the 50. That would be the average score with a standard deviation of 10. So when we tried to find out if we could distinguish different groups, then we found 3 different groups. The low group, 17 people, and you can see there are 2 standard deviations below the average score. Then the biggest group, they had a middle self-efficacy score, and 70 people had the high self-efficacy score. And when we tested this, there was no change over time. So it seems that if people are in one of these trajectories, they stay in one of these trajectories. They don't improve or get worse over time. We also looked at depression and anxiety, and here we see more or less the same pattern. For depression, a score of 8 is the cutoff score. Then you have probably, and 11 it's possible. 8 is possible, 11 is probably depression, anxiety problem. And we see average score of 6.6, then it goes down to 5, goes up again, goes down, goes up, goes down. So it's a wave. And there's no change over time when you do the statistics. And it's the same for anxiety. And if we look at the trajectories that then we found 2. One low depression, the biggest group, 67%. And the other group is high, and you see that they are above the 8. And apparently they are going above the 11, the probable depression. For anxiety, we see a slightly different trajectory course. We see 4 trajectories that we could distinguish: a very low, big group, and a low, moderate low, 200 people total. And there was a small group with a high anxiety, and even smaller group, but I think these are the people that we need to focus most, the very high anxiety. So we could distinguish 3 trajectories for self-efficacy, 2 for depression, and 4 for anxiety. And all these trajectories stayed stable over time, at least in the first year. We have to redo that for the latest data. And we could find that these trajectories are connected with each other. And patients that are adjusting well, so they had a low mood, depressive mood, or low anxiety, they could be distinct. They predict pretty well by their high self-efficacy scores. But the other way around, it didn't work that well. So people with high depression score and high anxiety score could not be easily found by a low self-efficacy scale. So there are more, also people with higher self-efficacy end up with depressive mood or anxiety. So I think we still have to measure mood and self-efficacy. This is a moment for me to relax and ask if there is a question about this study. So far? I hope to have some time for discussion in the end. I don't know how much time I have left. But I'll go on with the second study. This is a study that is in preparation by Diana Reimer. Diana Reimer is a doctor-to-be in the Hoogstraat Rehabilitation Center in Utrecht. And she's preparing this study where she is looking at the self-care, self-efficacy, and see the relationship between that and secondary health conditions. And the aim was to describe a course, both of the self-care, self-efficacy, and the secondary health conditions, and to describe their relationship, but also to examine the determinants of self-care, self-efficacy. So she used the self-care, self-efficacy scale and the spinal cord injury secondary condition scale, discharge 6 months, 12 months, and she is the first to use the latest data 3 to 5 year post-discharge. The self-care, self-efficacy scale, it's a scale that was based on the self-efficacy for managing chronic disease scale, and that's a scale that exists for many little scales, and we used the general self-efficacy scale and adapted that scale for our purpose, and we used 5 questions. They also start with the phrase, how confident are you that you can? And then 5 questions come, and they can be answered on a numeric rating scale, 0 to 10, and it looks like this when you put that in the questionnaire. So we try to find the self-care scale, self-care aspects of spinal cord injury, and put that in this scale. For the secondary condition scale, it consists of 16 questions, and we used 12 of them, and we used the 12 that can be influenced by behavior of the people themselves, like spasm, pressure injuries, things like that. And they can be answered on a 0 to 3 scale, not experienced or insignificant problem, mild or infrequent problem, moderate and significant. When you put that in a scale, in a questionnaire, it looks like this. Then for the figures. For the self-care, self-efficacy scale, it ranges from 0 till 50. You see that the mean score is 38, then it goes up 39, 37, 39, so it stays stable over time. And actually, that's more or less the same for the self-care, the secondary condition scale. There is some changes, but statistically not significant, so no change over time. When we look at the relation, or Diana looked at the relation, she saw that there was a strong negative correlation between the self-care, self-efficacy, and the burden from the secondary conditions, at least at discharge, 6 months after discharge, and 1 year after discharge. And this correlation gets weak in the latest data 3 to 5 years after discharge. So next, she looked at the determinants of self-care, self-efficacy, and I will talk you through this one because they will come more in the presentation today. Diana performed a regression analysis, and in the first model, she only put the demographic variables that had a correlation with self-care, self-efficacy of 0.10 or below that. And then you see that the sex, male, female, age, having a partner, and higher education, they were the determinants that were had a correlation, and they explain 13% of the variance of the self-efficacy. In the second model, she added the lesion characteristics. And then you see that 15% of the variance can be explained. That means that only 2% is explained by the cause of the injury, the motor completeness, or the level of injury. So the level characteristics hardly add any explained variance. While the psychosocial characteristics, they explain an extra 15% of the variance. And then especially the resilience seems to be an important one for this explanation. So also the self-care, self-efficacy did not change over time, as did the secondary conditions. The burden from the secondary conditions have the same. In the first year, there's a negative correlation between the self-care, self-efficacy and the secondary conditions as they experienced. And self-care, self-efficacy is significantly related to the psychosocial characteristics and especially with resilience, while the lesion characteristics are not related. So when we put these two studies together, we see no change over time for self-efficacy, at least not in the first year. And that's not what we expected, because I just said that it was a state variable that should change over time, but it did not. So, theory is incorrect, or our skills are not sensitive enough. And I happen to think the last one. Any questions?
Can you comment on the last point?
I still believe that the theory, and that's what I experience as a clinician, is that the confidence that people have about how they handle their spinal cord injury, it changes. It changes when they have more pain. It changes when they have a pressure injury. It changes when they have a urinary tract infection. It changes all the time, but we do not see it. So I think the skills are not sensitive. Yes, Jane.
So do you think it's something else, or like appraisals, or what else might be going on to impact or influence?
Do you need me to repeat that question for them?
The question that Jane asked, what do you think that it is? Is it appraisals or something else? I think that the confidence, that will change. But we are not able to capture that with the skills that we have at the moment. So we have to develop more sensitive skills, more sensitive measurements to capture that change over time. And yes, it's influenced by our appraisals, of course, because appraisals, self-efficacy is a sort of appraisal. How do you appraise your situation? How confident are you? It's an appraisal, you could say. Yes, then.
You had a correlation with resilience was very high.
Yeah.
Was there actually a resilience measure embedded in the question?
Yeah. We used the Marcel?
Conner-Davidson resilience.
Yes, thank you. The Conner-Davidson. Yeah, the Conner-Davidson resilience scale. Yeah. It was in the big list, but you overlooked it probably. I forgive you. The third study that I will talk to you about is a study that I'm preparing. And when I say I am preparing, it looks like I'm writing it all by myself. That's not the case. There's a lot of people helping me, and there's a great team. But I do the first analysis and writing for this study. And in this study, that's one of the things that was, when I started my PhD, this was the question that I really wanted to answer. Can we, at the start of the rehabilitation, know what people are at risk 1 year or even longer in time that are at risk for developing problems like depression, anxiety, secondary health conditions, all kind of things. Can we predict that at the start of the rehab? So what I am doing right now, not right now, but when I get home again, and I used the HEDS, Hospital Anxiety Depression Scale, the secondary condition scale, and almost all the other determinants, and we used that at admission, and we used the HADS and the secondary condition scale 1 year after discharge. And these are all the determinants that we use. Quite a lot of the demographics, all of the spinal cord injury characteristics, and a long list from the psychological aspect that we all gathered at admission. And we put that in a backward regression analysis, where one for depression as a dependent variable, one for anxiety as dependent variable, and one for the secondary condition as dependent variable. And all the other variables with a correlation, with a p-score of 0.10 or lower, they were put in that regression. And then we see that for depression, we could explain 40% of the variance by these 6 scales. The HEDS at admission, the anxiety at admission, if people have had psychological help before the spinal cord injury, the quality of life basic data set, University of Washington self-efficacy scale, and the ICQ is illness cognition questionnaire. It consists of three scales. One of them is acceptance. And ALE is the appraisal of life events, and there the appraisal of threat. These 6 aspects, they explain 40% of the variance in depression. For anxiety, we could even explain 52% of the variance by only those 4 characteristics. That's the anxiety at admission, the quality of life basic data set, neuroticism from the ISAC personality questionnaire, and also the threat appraisal. Those 4 explained 52%. And then for the secondary condition scale, we could only explain 16% of the variance by the HADS and the ALE threat. So it seems that although we can explain depression quite well, anxiety, that's not the case for secondary conditions. So at admission, all the determinants that we captured are not explaining if people are getting problems with the secondary conditions, the burden that they experience from the secondary conditions 1 year after discharge. So I think we should look at other things, probably the discharge characteristics. People have had any problems with secondary conditions during their first inpatient rehabilitation, the pain that they are having at the end of the rehabilitation. I don't know, but we cannot explain it by our admission data. So far, any questions? Dan?
I would argue that the most important variable is overall cognitive ability. The brighter you are, the better capacity you have to problem solve, separate from all those variables. So trying to get a proxy, say, reading as a proxy for intellectual ability, imperfect, but it correlates.
But then you would expect that the education level would also pop up, and it's not there.
Right.
I mean,
it could be it's not showing up at an educational level, but the smarter the person is, the more capacity they have to problem solve.
Yeah, but we didn't find that it didn't explain education level did not explain the secondary conditions.
I guess there's different kinds of smart.
There are different kind of smarts, actually. Yeah, that's so true. So true. Yeah.
I might have missed it at the time. Did you record in any way patients that have had either training through patient education or one-to-one explanations around self-management in terms of pressure ulcers or bladder management or that?
We don't have data on that specific, but all people follow in the Netherlands more or less the same program. According to educational programs, they are standardized along the day 8 standardized. They are more or less the same in the 8 centers. There are some differences. And people are explained how to take care of themselves. But we did not capture that for every individual, no. And I will continue to the next study. The relationship between participation and secondary health conditions. This is a paper that's in preparation by Marcel Post. And he will do that because I don't think this is in the top of the list yet. He will do that of all the work that André Land did for us. André Land is another doctor to be, also from the Hoogstraat Rehabilitation in Utrecht. And his aim was to explore the changes in participation for people living with a spinal cord injury, and to explore if we could predict if the secondary health conditions in any way had an influence on participation. So we used the secondary condition scale, we already saw that, pain and fatigue, and also the participation part of the user. User stands for Utrecht Scale of Evaluation Clinical Rehabilitation, and then the participation part of it. And André used the discharge 3, 6, and 12 months post-discharge measurements. This is how the pain and the fatigue looks like. And for the user P, has 3 scales: the frequency, the restrictions, and the satisfaction. And this scale is transformed into a 0 to 100 scale with higher scores reflecting a better participation. And better participation means more frequent, experienced less restriction, and experience more satisfaction. So keep that in mind, that higher scores is a better participation, so less restrictions experienced. What we did at admission, we asked, how did you participate before you had your spinal cord injury? That is a bit tricky, because I think that people are idealizing, is that the English word, their situation before the spinal cord injury. But it's the best that we have. And at least for the frequency, we can get that very good, because you see how much did you work, how much should you do unpaid work, education, things like that. So I think for the frequency score, this is pretty good. For the satisfaction, I think it's probably an overestimation of what people really did experience at that time. When we look at the data, for the secondary conditions, we already saw this one. André looked at the mean scores and compared them. So from discharge to 3 months, you see a decrease of the problem experience. Pain, we see a tremendous drop in pain during rehabilitation, then it goes up again and it stays more or less the same. And that's what we see for fatigue. For the participation, you see the pre-morbid scores. So people had a score of 36 for frequency, And there's a tremendous drop after 3 months. It goes up every time, every next time. The restriction, we did not measure that at pre-morbid. And there you see that the restriction is going up every time, more or less. And that means that they experience less restrictions. For the satisfaction, it goes up till 6 months post-discharge, and then it stays stable. So another regression analysis. When we look at the frequency, we can see that 16% of the variance can be explained by the demographics, another 1% by the lesion characteristics, and only 3% extra percent by the secondary conditions. So most of the frequency, most of the variance from frequency can be explained by age and education. And that's just like the normal population, you could say. For the restriction, we see a somewhat different pattern. 9% by the demographics, another 14% by the lesion characteristics. So lesion characteristics do have an influence on the restrictions experience, and another 10% by the secondary conditions, especially the secondary condition scale, but also fatigue. For satisfaction, 7% of the variance can be explained by the demographics, another 5% by the spinal cord injury characteristics, and 10% by the secondary health conditions. So what can we conclude? The course of participation significantly improves the first 6 months after discharge. After that, it stays more or less the same, except for a restriction that seems to improve even in a longer time. The secondary condition scale is the strongest independent predictor in the variance that of the experienced restriction and satisfaction, but not in the frequency. And for the frequency, the normal aspects that we see, age and education, seems to have the biggest explanation. Question. It's very hard when you have to talk 1 hour and to get the audience with you, and so I try to make it a little bit interactive.
And in a second language.
and in a different language. In the end, you won't notice anymore. I don't know.
Well done. Any questions from the audience?
Now, is someone looking at the platform users if they have a question? Because I cannot see that.
Not yet.
Not yet. All right.
Congratulations, great news about the discourse presentation, discourse workshop.
Thank you.
Before your talk.
Yeah. This is not helping me. All right.
Actually, can you go back to that last time? I was just going to ask you about this. Just explain to me in everyday language the restriction one. So that everything improved for 6 months except for restriction.
Yeah, that means that people, even after 1 year, they experience less restrictions. So the restriction is going up, so it's getting better. Okay. So they are experience less restrictions.
Yeah.
While the other frequency and the satisfaction stays more or less the same after 6 months. The restriction is less important. Less important for that. Yeah. Yeah. All right. Then I will go to the last study I will talk with you about. It's a study that's published in BMC Psychology. It's an open access. If you want to know more about that, please go and see over there. It's about learning self-care skills. And this is a qualitative study that we did where we would understand how people with spinal cord injury experience the learning of self-care. And in this interview that we did, we also asked about self-efficacy, about the confidence that they have. So I will not talk about the self-care part of this article, read it yourself. I will talk about the self-efficacy part today. Yep. Further, we did some interviews with professionals. I think that's in the next thing. For the patients, we interviewed 15 patients that just had discharged from their rehabilitation. We interviewed them between 2 and 5 weeks after discharge, and we asked them how they experienced the self-care, how it was learned to them, what the professionals did, how they did it. And next, we also interviewed professionals, and we interviewed different kind of professionals. We interviewed 2 nurses from FE Center, occupational therapist, physiotherapist, and rehabilitation physician, and a social worker. I did not interview the psychologist because they are my colleagues and I work very close with them, so it would interfere with that. So we asked the social workers instead. 5 rehabilitation centers participated in that, and that makes 6 per center, makes 30, and I did 1 extra to practice with the nurse in my own rehabilitation center, and we entered that. The professionals from my own center I did not interview. That was done by Eileen Scholte, PhD candidate that works very close with me. About the self-efficacy part, the confidence part, what was very surprising for me is that most people say that gaining confidence, that's something that I have, that's part of me, that's just who I am. So they think they are the ones that did that gaining of confidence. When you go further into detail and try to find out what was associated with the gaining of confidence, then you saw that the experience that they had in the center, but also all the information that they gathered from the professionals, and some put it very elegantly, it's a combination of my own attitude, the contribution of the team, and that's not one person, but it's the whole rehabilitation team, and the experience of doing things. So one participant put it this way: I got confidence of myself. That's the part, that's me. And further on in the interview, how the rehabilitation center has helped. He say, by stimulating you in all sorts of ways, and creating the conditions under which you can make progress. I mean, it's there and it's offered to you. They, professionals of the team, see things sooner than you can. So I think this is very nicely put how people experience that. When we look at the professionals, I've not done the formal analysis yet, so it's more a first impression. All professionals are working with the confidence of their patients. But when I ask them, what do you do? And they're quiet. What do I do? And after that, they are going to tell you what they are doing. So they're not very conscious of what they are doing and how they are doing it. But when they are talking about it, they do the right things. And they do it in the right time, I think. So they are unconscious, how do you call it in English? Wat? Nou, onbewust bekwaam, Nederlandse collega's. Onbewust bekwaam. Well, they also don't know it. No, they're sleeping. So, both patients and professionals seem not fully aware what the role of self-efficacy is in the rehabilitation. And a lot of people and professionals are not aware of their own role in this.
I think you might have been subconsciously aware that they're
Yes,
yeah.
they're unconsciously aware.
Yeah.
Thank you. So I slipped this one, if you don't mind. This is what these information that I got from the professionals, especially. That was when I was thinking what we have to do if we want to improve and the confidence of our rehabilitation patients. We have to train the professionals. We have to be sure that they are doing the right things at the right time in a conscious way, so that they are using it correctly. And in Dutch, this is nice. The training that we put together is called Samen bouwen aan vertrouwen. That's a nice rhyme, but when you translate that into English, it's getting this together building on confidence. Together is applying to the whole team. I think confidence is the one theme that binds us as a team. Everybody is working on confidence, not only the psychologist, all the team is working. By training the professionals, you can have some goals. First, you can learn about the influencing mechanisms. 4 are formulated by Bandura himself. Performance accomplishments, that's not another thing than just doing. By doing, your confidence is growing. Vicarious experience, if you see someone else doing things, especially when this other person looks like you, if he can do it or she can do it, then I can do it. So your confidence will grow if you see other people do it. The verbal persuasion, if someone who knows, a professional, when the PT says, I think you can stand, then you are more confident that you can than when he would not say that. And our physical feedback and perceived emotional arousal is very important. If you think that your sweating is part of that, your system is warning you that you don't have to stand up, then you won't do it. Well, if you know from, all right, this is part of the attention, then it will be easier to do. And James Maddock also added the 5th one, imaginal experience. If you imagine the things you have to do, then your confidence will also grow. It's like doing the things in your mind. It's not as strong as doing it. It's actually doing it, but it still works. The next goal was to use the different learning strategies, and we used the learning strategies from Kolb, because you can change your influencing mechanism according to the learning strategy. And I think the most important goal is that you can do this interdisciplinary. This is the one theme that covers all disciplines, as I said before. So what did we do? We made an e-learning. I give the professionals training a whole day, interdisciplinary, so the nurses are with the PTs and the physician all together working on confidence. And after a month, there is a comeback day. I don't know what's that in English. Comeback day? Half a day, you come back to talk about what you learned and stuff. 5 minutes, well, then I have to see if this is working. This is part of the, this is part of the e-learning. The accomplishments I give you, watch and see what of the 5 influencing mechanisms you see in this movie.
Hallo Petra, kom maar verder. Ik ben nog even met het bezig en een aanleiding doen. Goed Petra, we hebben gisteren een spierstaat gemaakt van je been. En daaruit blijkt dat het voldoende kan moeten zijn om op te kunnen staan. En wat heel erg helpt, is dat je eerst in gedachten, dat heeft het even gelopen, dat je in gedachten ook echt gaat opstaan. Probeer je voor te stellen, we gaan eruit eerst voor de stoel zitten, daarna zet je je been op de grond, je pakt de doorvast en dan gaan we samen opstaan.
Ja. Ik voel helemaal van het steeds opkomen en mijn hart voelen bonken. Dus ik wil heel spannend. Wat je al zei, dat is de adrenaline die je gaat. Die ook om dit soort dingen te kunnen doen. Ik denk dat het gaat lukken. Oké. Goed, dan gaan we staan. Ja, eerst stap, kom maar voor ons toe. Ja, goed op de kop. Stap de brug vast. Neus naar voren. En staan. Oké. Stop. Ja, benen trekken. Ja. Oké, handen naar voren. Trek de knieën. Oké. Trek de knieën. Goed zo. Oké, neus naar voren, weer naar achteren. En dan naar achteren. Heel goed. Nou, dan gaan we nog even terug gaan. Ja, goed. Dat is echt gestaan. En ik dacht echt dat ik dat niet zou. Dat er wel heel veel krachtinspanningen hebben. Ja, maar door die inspanning heb je echt iets bereikt. En dat is voor de toekomst. Dus morgen gaan we weer door. Ja. Goed gewerkt. Dankjewel.
So, which of the 5 did you see? All of them. Great audience. Yes, we saw them all. Yeah. And if you want to know which part you missed, please come to me. Yes. Another lesson that we learned is that the skills are not sensitive enough. So we tried to put together a skill that is more sensitive to change over time. 10 questions with the numeric rating scale 0 to 10, 4 about general self-efficacy, and 6 about disease-specific self-efficacy. And we put it together in a way that you can also very easily add some questions. For instance, we are now preparing a study on a myosuit. That's a flexible exoskeleton. And we tried to make some questions about how confident are you that you can walk with this suit. So make it very specific. We made 4 or 5 questions about it, and you can very easily add this questionnaire. So it will look like this: the general and disease-specific self-efficacy scale, GATSES. I don't know. I hope that's not an English slang word for something. These are the 4 general self-efficacy questions that you can deal in general with unexpected events, accomplish the things you set out, successful to overcome challenges, and ability to solve problems. And for the disease-specific questionnaires, these 6 we have put together. One of the things when you look at literature is that probably a lot of the self-efficacy skills are not actually self-efficacy skills, but are more motivational skills. So we added the phrase, if you wanted to, just to move out the motivational part of the self-efficacy. And then these are the 6 questions that we came up with. We use that in the extra measurements 3 to 5 years after discharge, together with the general self-efficacy, with the University of Washington self-efficacy, and with the self-care self-efficacy. So I hope to be able to publish that shortly. So the take-home messages. Our current skills are not sensitive enough. Talked about that. You can increase self-efficacy, you can increase the confidence that you have. And I think wise thing to do is by training our professionals. It's very little time, very big impact. The increase of self-efficacy might also protect from depression and anxiety. Secondary conditions after 1 year could not be predicted, not by demographics, not by spinal cord injury characteristics, nor by psychological determinants. Participation improves, especially the first 6 months after discharge, then stabilize, except for restrictions, that goes up. And secondary health conditions. Secondary health conditions. Sorry, just the 1 minute is in my head. Just read it. Yeah. Are there any questions? Any questions? I hope it was not too long for you. Yeah, question.
First of all, thank you for this great talk and this really, really impressive research. I'm quite impressed by that.
Thank you very much. The audience, I don't know your name, sorry.
Caroline.
Caroline was, well, she says it's an impressive piece of work. Yeah, thank you.
I more have a comment to your first study.
Did you happen to write down the slide number?
I did write down the slide number 23.
Which one?
Yes. So, I mean, it's around everything. But so here with the trajectories, you see 3 patterns which are kind of like the same pattern, similar levels.
Yes, that's
so
correct.
Which is really interesting. And I was wondering if maybe one day you would be interested to, instead of using a classical trajectory analysis, a latent transition analysis, because then you have the chance to see the within changes instead of having different layers of trajectories. And so you can have the chance to observe what happens in between these groups. Because, I mean, they are classified by entropy, so you have not a chance to see whether they change. But with the transition, you might have the chance to see, okay, are these people jumping around?
Yeah.
And then,
but before, otherwise the platform audience will not follow this. And I'm completely lost your point. When you see these 3 trajectories, they are grouped together. It would be interesting to see what's happening in between those groups for every patient, because when you look at the individual scores, you see that there are more changes than we see in the average scores for all the people in one trajectory. I believe that's true. That will be very interesting to see. I don't know how you do that kind of statistics, but probably we should talk about that.
yeah, it's huge fun to do so.
I'm sorry?
It's huge fun to do this kind of analysis.
Yeah.
And then I have a slight question to the depression trajectories.
Yes, this was 23, so that will be 25, I guess. Yes?
Yeah, I was just wondering, do you have any explanation why you just found 2 kinds of trajectories and not, I don't know, 4?
Yeah. The question is, why do I have an explanation why I only find 2 trajectories and not 4? Well, from a theoretically point of view, you would expect 5.
Yes.
A low, a middle, a high, increasing. And one of our colleagues from the States, yes, Bonanno, he found, I believe, those 5 trajectories, or 4. And we only find these 2. I don't have a sound explanation, no. for the trajectories of self-efficacy, this was done by Ashley Craig before, and he found 4. But he only found 4 because he left the statistical criteria. And he went to interpretational criteria, and then he found 4. But when you look at the statistical criteria, he also would find 3. But he describes 4 in his article, but it's not based on statistic criteria. Bonanno found 5, and we only 2 for depression. I don't have a sound explanation. Probably someone else has. Would be nice to hear.
How far out was Bonanno data?
I'm sorry?
How far out?
2 years.
It was 2 years.
2 years. So probably if we use the new data 3 to 5 years, that would differ. I don't know. We have to redo the whole statistics again. Yeah, would be interesting though. Yeah.
It's really interesting because actually I also found 4 at the chronic health conditions.
In chronic.
So not focusing on spinal cord injury,
No.
but I had a comparison sample of healthy individuals of the Swiss population. And in the healthy population, we also only found 2 trajectories versus 4 in the chronic health condition subsample. So this was really interesting to me that you found 2.
Yeah.
Very interesting.
Okay, I think in the interest of time, we have to wrap that up. I just want to say, from my point of view, I loved the last bit in
Probably you
particular.
have to do that in the.
Oh yes, I have to do it there. I loved the last bit in particular where you talked about the need for us as psychologists to work with professionals, to work with the team, to encourage the sort of promotion of self-efficacy. I think there's a lot to be said, more to be said about that. So thank you, Tijn, very much.